Position of the patient depending on the sector to be treated and strategy, tips and tricks. Background. The emergence of hybrid operating rooms stems from the need to perform endovascular techniques in surgical environment. This allows for the execution of hybrid procedures and the management of complications arising from endovascular interventions. With advancements in technology, these rooms now offer improved image definition and stability, reduced contrast medium and radiation usage, and greater speed and versatility in imaging projections, along with operator self-management capabilities. This chapter provides guidelines on the setup of hybrid operating rooms for different common procedures in our specialty, as well as positioning for C-arm placement. Hybrid operating room setups. It is essential that the patient is consistently positioned to standardize procedures and maintain the anesthesia workspace in a fixed location.
This ensures that positional adjustments required for each procedure can be made only by moving the C-arm and surgical table. Given that each procedure may require one or more different arterial accesses, it is crucial to follow a systematic approach. The following diagrams summarize the setups we propose.
Endovascular repair of occlusive disease in the aortoiliac segment. In these cases, retrograde femoral access is typically used, so the setup in Figure 1 is appropriate. If left brachial access is anticipated, the setup shown in Figure 2 can be an alternative. Endovascular repair of occlusive disease in the femoropopliteal segment.
The setup depends on whether an antegrade or retrograde femoral access is planned, based on the location of the femoropopliteal lesion. Proximal lesions favor retrograde access, while distal lesions favor antegrade access. Antegrade femoral access. Following the setup shown in Figure 3, operators will position on the patient's left side. A table at the patient's feet might be prepared for potential retrograde puncture. Retrograde femoral access. The setup depends on the limb being treated. A. For left limbs, a right retrograde puncture is used, with the setup shown in Figure 1. An additional screen may be prepared on the patient's left side for possible retrograde puncture. B. For right limbs, a left retrograde puncture is used, with the setup shown in Figure 4. The limitation is that operators will need to work with their left hand. An additional screen can also be prepared on the patient's right side for potential retrograde puncture.
Endovascular repair of occlusive disease in the infrapopliteal segment.
In these cases, antegrade femoral access is typically used, and the recommended setup is shown in Figure 3. A table at the patient's feet for possible retrograde puncture might be added.
CARM.
In the case of the C-arm, an optimized workflow reduces surgery time and the radiation used, which can even be lower compared to the fixed arm if managed correctly. Recommendations and tips are provided to optimize the use of the C-arm.
Tips and recommendations.
Preoperative planning. Device placement. Ensure that all devices are correctly placed before the start of surgery. Proper positioning of the C-arm is crucial for optimal imaging and workflow. Team positioning. Define the positions of the surgical team, including surgeons, anesthetists, radiology technicians, and nursing staff. Optimized placement can reduce surgery time and radiation exposure. Positioning of the C-arm. Alignment. Position the C-arm to allow for easy maneuverability and access to the surgical site. Make sure it is aligned correctly to obtain clear images without having to reposition frequently. Height adjustment. Adjust the height of the C-arm to the appropriate level for the specific surgery. This can help avoid excessive radiation exposure to the patient and staff. Radiation safety. Minimize exposure. Use pulsed fluoroscopy instead of continuous fluoroscopy to minimize radiation exposure. Ensure that the lowest possible dose of radiation is used while still obtaining clear images. Protective gear. Ensure all staff wear appropriate radiation protection gear, including lead aprons, thyroid shields, and lead glasses. Use lead barriers whenever possible. Image quality. Collimation. Use collimation to focus the radiation beam only on the area of interest. This not only reduces radiation exposure but also improves image quality. Image acquisition. Acquire images at the optimal angle and position to ensure high-quality visuals that assist in accurate diagnosis and treatment. Maintenance and calibration. Regular checks. Perform regular maintenance and calibration of the C-arm to ensure it is functioning correctly. This includes checking the alignment, image quality, and radiation output. Software updates. Keep the C-arm software updated to benefit from the latest features and improvements in image processing and radiation safety. Training and protocols. Staff training. Ensure all staff are adequately trained in the use of the C-arm, including its operation, safety features, and troubleshooting common issues. Standard protocols. Develop and follow standard operating procedures and protocols for the use of the C-arm to ensure consistency and safety in its application. Optimizing workflow. Efficient use. Plan the workflow to minimize the need for moving the C-arm during the procedure. Efficient use of the device can save time and reduce the risk of contamination. Communication. Maintain clear communication among the surgical team to coordinate movements and positioning of the C-arm during the procedure. Documentation and review. Image documentation. Ensure that all images captured during the procedure are properly documented and stored for future reference and review. Post-procedure review. Conduct a post-procedure review to assess the effectiveness of the C-arm use and identify areas for improvement.